Today I will present the first results of a multi-site study that was conducted to assess virological failure, drug resistance, and third-line needs among patients on second-line ART. In resource-limited settings, we have a standardized first-line and second-line regimen available. Once patients fail on first-line, as Elisabeth just indicated, they are switched to a second-line treatment without using a genotype. So there's a standardized second-line regimen composed of 2 NRTI drugs and characteristically a protease inhibitor drug, which has a higher genetic barrier to drug resistance and is also very potent. Example resistance is 3-TC-TDF with lopinavir boosted by ritonavir, and more recently also the protease inhibitor atazanavir. So the number of HIV-positive patients on second-line ART is increasing, specifically now with rollout of access to routine viral load monitoring. However, we don't have a standardized third-line approach available in these settings. So current recommendations consider the use of new generation drugs who have minimal cross-resistance to existing treatments. This includes protease inhibitor darunavir, the new NNRTI etravirine, and a new drug class integrase inhibitors. This includes raltegravir and dolutegravir. These drugs, however, are very expensive and of limited access in the settings where we work. And one of the key questions currently in debate is also, do we need a resistance genotyping test in order to tailor third-line regimens, or is it sufficient or appropriate to use a generic approach with a preset composition of drugs as a public health approach? The objectives of our study were to assess the proportion of virological failures and to describe the drug resistance patterns among patients on second-line treatment. And among several secondary objectives, we also aim to assess outcomes at 6 months and 12 months after treatment adaptation. We decided to go for a comprehensive approach to conduct the study in 3 different sites. This includes the outpatient HIV clinic in Homa Bay District, Kenya, as well as the Shiratsulu rural program in Malawi that Elisabeth just introduced in more detail, as well as the Altomei Referral Center in Maputo, Mozambique. We included patients of age 5 years and older, still retained in care and on second line for at least 6 months, and they had to have a history of failing a standard first-line regimen. And our target was to include 40 to 50% of eligible patients per site. The study design was cross-sectional with the following elements. We performed a clinical exam, a patient interview, and we measured ARV concentration in plasma and hair samples as an objective marker of adherence. And the main measure feeding into our main objective was plasma viral load, with resistance genotyping performed as soon as patients have, or when, for those patients who had viral load higher than 500 copies per milliliter. Enhanced adherence counseling was provided through routine program for those failure patients, and ART regimen was adapted based on the genotyping results. And we also have follow-up appointments for those failure patients at 6 and 12 months after intervention. This table depicts participant characteristics at inclusion. We included 355 patients in Kenya, 242 in Malawi, and 205 in Mozambique. The majority of participants were adults with a median age ranging between 38 and 42 years across sites. And we have a second-line regimen at inclusion that is site-specific, whereas in Kenya and Mozambique, the majority of, or all patients were on a lopinavir-based regimen. In Malawi, most were on an atazanavir-based regimen. The majority among all the sample were on a 3-TC-TDF backbone. Years on second-line treatment at inclusion ranged between 2 and 3 years across sites, and the majority of patients were in a good clinical condition at inclusion, meaning WHO clinical stage 1 or 2. Here we see the virological outcomes at cross-sectional assessment, showing here the results by WHO recommended failure threshold 1,000 copies. And you can see that in our study samples, we have failure rates ranging between 17 and 27%, which on the other hand translates in an overall good virological response to treatment with around 83 and 87% suppression in Kenya and Malawi, and a little bit lower in Mozambique with 73%. And it's of note that in our sample, in all 3 sites, we found twice as high failure rates in the age group below 19 years, even though numbers are small. Resistance genotyping was performed, as I said, for everybody with viral load above 500 copies. This is 65 patients in Kenya, 39 in Malawi, and 60 in Mozambique. And all the following data that I'll present is on this subgroup of virological failures. This graph depicts resistance high-level score by ARV drug class among failures. You see that we have quite a similar pattern in the 3 study sites. The majority of patients had at least one high resistance in the NNRTI as well as in the NRTI class. We also detected between 20 and 30% protease inhibitor resistance, and only 10 to 15% of patients had no high resistance in all of the drug classes. The following graph breaks down resistance by individual ARV drugs, and I'd like you to focus first on elements that are comprise second line. So in the NRTI treatment class group, 3TC was highly affected, with the majority of patients being resistant. This is not so surprising because this molecule has already been used in first line and it has a very low genetic barrier to resistance. About 1 in 5 patients in all 3 sites had high resistance to TDF, which is the other more prominent backbone NRTI molecule, whereas other NRTIs are affected at a little bit higher levels, ranging up to 60%. When we look at protease inhibitor resistance, the key component of second line, we find resistance to lopinavir and atazanavir in all 3 sites. When you focus on Kenya and Mozambique, where all patients are on a lopinavir-based regimen, we see 24% lopinavir resistance in Kenya and 17% in Mozambique. At the same time, this confers cross-resistance to atazanavir. In Malawi, however, where the majority of patients are on an atazanavir-based regimen, we have a little bit lower PI resistance, 8% to lopinavir and 13% to atazanavir. And what I would like to point out, what is reassuring, that we have no high resistance detected to the new protease inhibitor darunavir, which was suggested to be a component of third line. There was 1 patient in Mozambique that scored with high resistance. On the other hand, etravirine, the new generation NNRTI that was proposed as a component of third line, we identified around 10% of high resistance in each of the sites. So this table depicts how resistance pattern translated into ART regimen adaptation. And for the Kenyan example, in fact, 37% of patients did not require treatment switch. They didn't have major resistance, but we took the opportunity to switch to a simplified regimen from lopinavir twice a day to atazanavir once per day. 32% of patients required to be switched to third line. This was based on protease inhibitor resistance and often combined with NRTI resistance. And 28%, this is not what I want to show, 28% of patients required optimization of their second-line regimen, meaning the NRTI backbone had to be improved. And what I would like to point out here, I'm sorry, this is really not working, that using the genotype results, we could really have a tailored approach by using new molecules depicted in green, as well as recycling existing drugs depicted in blue. This was true for third line as well as for optimized second line regimen, where mostly raltegravir was needed for a subgroup to rescue the regimen. And this shows the first results of the follow-up that I mentioned, specifically for Kenya at 6 months. We have good virological suppression among patients switched to third line, as well as on optimized second line in the range of 80%, whereas those put on a simplified regimen who didn't have any major resistance, we have only 59% suppression. So we don't have all the data yet available, but most likely insufficient adherence is still an issue, but we will be able to assess that with ARV concentration measures. And we will also perform another genotyping at month 12. So in summary, we saw overall good virological suppression on second-line treatment, and among second-line virological failures, we see that all available ARV drugs are affected, but to different levels. The majority of failures required either optimization of their second line or a switch to third line. And regimens could be adapted by using first generation drugs as well as new generation molecules in combination. In conclusion, resistance genotyping is needed for optimal ART regimen choice in second line failures. This really allows tailoring the regimen based on drug resistance. And importantly, this allows to support preservation of costly new generation drugs, not only for the measure of cost, but also to keep them for the next failure event of these patients. Nevertheless, we really urgently need access or better access to these new generation drugs, specifically darunavir and integrase inhibitors. As you could see, they were required for a good proportion of failures as salvage regimen. And I'd like to thank you and everybody involved in this study.